Hello, my name's Gareth Morgan. I'm director of the Myeloma Institute in Little Rock, Arkansas. I'm here in the Myeloma 2017 meeting in Edinburgh in Scotland, and I'm joined by two colleagues, Nina and Leif. We've had a very exciting day in the meeting, and we'll go through some of the exciting things that were discussed. So, Nina, perhaps you could tell us what was discussed about MRD in the meeting.
Yeah, well, we had a very heated discussion, a great panel where we had a wonderful lecture by Bruno Paiva, and thereafter discussed what the separate MRD results have been from various clinical trials. And one of the most important things I think that came out of that is that MRD is for certain very important when we talk about prognosis. But one of the other things that came out is we're not sure what to do with the information. So we don't know how best to get to MRD negative yet, and we're not sure what to do when someone is MRD negative or positive. But I think this is really important because as we talked about it, MRD may be the new CR, and I think that'll be really helpful for us to plan future clinical trials. We talked a lot about making MRD an endpoint and maybe making clinical decisions based on that in a clinical trial, and I think that will be very helpful to our patients to both limit toxicity and to our society to limit cost.
So, Leif, do you think we're there yet in terms of MRD as an endpoint?
No, I wish that we were there, and I hope that we can convince the regulatory authorities to allow us to be there, because I think we all think it's important and that we'll make advances much more rapidly. And I think that we've got endpoints that we can use today that we should be using more.
I think it was clear in the meeting that we're making progress, and each kind of meeting we seem to be getting closer to a position where we really can go to the regulators and talk to them in a meaningful fashion about using it in the clinic. We also heard quite a lot about new drugs and new mechanisms of action. Perhaps you could tell us a little bit about Nelfinavir.
Don't ask me about Nelfinavir. I'll pass on that one.
Are you
I can tell you about it.
Okay, tell us about Nelfinavir.
Nelfinavir is a protease inhibitor, and it's traditionally used as an HIV drug, but as it turns out, it can actually increase the ability of a cell to be sensitive to a proteasome inhibitor. And so we had a really nice talk about this by an investigator-initiated trial. So this was completely investigator-funded based on their own data, looking at the results of this and why it would work. And the idea is to combine Nelfinavir with a proteasome inhibitor, currently Velcade or bortezomib, but maybe in the future carfilzomib, and see if you can get a response in people who have been previously refractory to PIs. And so they were able to show a really nice response rate in their initial trial. I'd like to see this go further. They're going to plan more trials with this and hopefully with more support.
I've been lucky enough to use it a little in the clinic, and I've seen great responses, and it's a great example of an old drug that's being repurposed for a really important position in therapy, I think. What about the science then, Leif? There was there was a lot of great science today.
Well, one of the most exciting drugs is venetoclax, which is a drug which targets BCL2, protein we've known about for probably 20 years, but now have a good drug, and data showing that it works in about half of the patients who have a chromosome translocation between 11 and 14. And so it's really the very first time that we've got a therapy that targets a particular genetic subgroup of myeloma. And I think that's exciting, as is the mechanism of action. And then we heard that there are next generation molecules in the same vein that target proteins related to BCL2, like MCL1, which is really important. And so that's going to open it up to a lot more patients.
So he made a very strong case, I think, that MCL1 is going to be a very important molecule in myeloma. Which were the drugs you found exciting and the science you found exciting?
Yeah, I'm also excited about the MCL1 inhibitor, and it was funny because there weren't any before that could be used, and now I think there are 3 going into early phase clinical trials. And I think that it'll be interesting to combine that with a very intelligent sort of cell signaling pathway, how you would combine these drugs together with the drugs that we already have. And I think that'll be helpful for trying to get us away from toxic combinations, but more intelligent combinations.
So I was taken by the data on two new IMiD drugs. Specifically engineering those drugs for their mode of action, and the fact that they're seem to be 10 to 15 times more potent than the most potent one we have now. And I'm very hopeful that we'll have a next generation of these IMiDs in the clinic.
Yes.
I was also taken by the imaging. So
Yeah, I really
so what
thought-
do you think about that in your clinic?
You know, I think imaging is such a complicated issue because we all do it a little bit differently, we all feel a little differently, and the imaging technology has gone faster than the clinical trials. I think everybody can agree that having a positive finding on imaging at the end of treatment is worse than not having a positive finding, but how we use that serially to look at disease and the discordance between the different kinds of imaging is difficult, and I'm hoping we'll be able to make a matrix to figure that out better.
Yeah.
So an interesting young man from Würzburg presented data on 5, I think maybe
Yeah.
only 4 different traces for
Yeah.
PET. So what did you think of that?
Oh, I learned a lot today, things I hadn't heard of about the way these different modalities can identify different disease and possible significance it has, and then the new tracers that can be used. You know, I want to do it all the time on all my patients. We'll just have to figure out the best way to go forward.
Yeah, it was kind of not quite ready for clinical use, but to understand the biology of the disease, I thought we had what was it, F-methionine PET kind of shows up more lesions than you see on FDG PET.
Right.
Some are negative and some are positives. It makes you really kind of question what the biology of those lesions are.
Right, why are they different and not showing up?
Yeah.
And think about it, 20 years ago we weren't using PET, and now we use it all the time in lymphoma, for example. So there's room for us to grow and quickly.
So I think it'll come in as a sort of another biomarker of treatment response and possibly even an endpoint.
Endpoint, yeah,
So
combined.
I think it's really interesting.
One other thing I thought was really fascinating was the talk that we had about drug screening with in silico screening, and I think
God, yeah.
this is just something that's coming up. It's sort of a rebirth of a previous idea where we can do high throughput screens of drugs on patients' own primary cells, and I think that's very interesting because wouldn't we love to know what a patient might not respond to or might have changed to without exposing the patient. So I hope in the future we can do something predictive like that. What do you think?
Yeah, no, I thought it was fascinating and almost futuristic or hard to believe that you could get so much information about how a patient would respond to different combinations from just a 3 or 4 day culture.
Yeah.
Really.
So at one level, I would own up to not understanding it at any level from the start to the finish of the talk.
Yeah.
But taking images of a limited culture every 10 minutes or so for 4 days seems to give a real huge amount of information and adapting them to look at the immune system as well as direct cytotoxicity seem to be
Really neat.
yeah, but I can't claim to understand
How
any
they did
of
it.
No,
Yeah.
Absolutely.
No, but it's really interesting. I think that'll help us in the future because the toxicity profile is important. These patients that we see so often have had so many drug exposures, and you really want to limit them only to what you think will work. And if you could predict that, it would just be more ideal.
So the last session of the day involved some discussion around consensus. So,
Or lack thereof.
okay, Leif, where was there consensus?
Oh, there was a beautiful talk that listed where we had consensus, and it's around the general principles. We need to use induction. We think transplant's useful, maintenance. There's very, very broad principles. We are all agreed, and it's in the controversy is in the details of which drugs, how long, and how to sequence things.
Nina, where did you see the consensus?
Yeah, I think it was funny because Peter, who was talking about the lack of consensus, said actually we are all unified in this idea that we need to treat, intensify, consolidate, maintain, and we have that in together. This is for upfront myeloma, but the details of that are different. And I think as we decide, if we have a consensus on how to measure disease, what endpoints are important, we're actually going to be able to go backwards and get better answers in more novelly designed clinical trials. And that's what I like that Faith brought this up, that we really have to change the way we think about clinical trials to make them more efficient for our craft.
Yeah, kind of there are so many new agents. Putting them into clinical trials and bringing them to the clinic for patients is really what we're all about, I guess. So thank you very much for your attention, and we had a great day here in the meeting, and I hope you enjoyed listening to our discussion. Thank you.